All right, so now what we're going to do is we're going to talk about the treatment of COPD. Okay, so we've gone over the pathophysiology. You better have. You better have gone over the signs and symptoms of the diagnosis, because now we're going to go over how we would treat this patient. Now, if you guys watched the diagnosis video, we talked a little bit about supplemental oxygen, just again, based on that threshold that we kind of look at. When we treat a patient with COPD, probably one of the most important things that we want to do is to put the patient on supplemental oxygen based off of their actual O2 sats and their actual partial pressure of oxygen. So that's one of the big things. But again, even more important than that, what was the main 90 to 95% of the cases of COPD due to? Smoking. Stop smoking. So the biggest thing that we could do for the patient is to instill smoking cessation. Okay, maybe send them to different classes or things that they can utilize to stop smoking, okay? Whatever type of prevention measurements you can do. The next thing is we want to put them on, we want to make sure that we get them on their flu shots every year. So we also might want to do the influenza vaccine. And the pneumococcal vaccine. We talked about this in the pneumonia video, okay? So the pneumococcal vaccine is going to be also really important. If you guys remember, the big one is going to be PPSV23, okay? And again, the reason why we give this one is because if you remember, we usually start that at age 65, or in a patient who is 19 and who they're smoking, or if you have a patient that's anywhere up to 64 years old that has any type of immunocompromised state, cancer, HIV, sickle cell anemia, something of that nature. So these are the big things. We want to do smoking cessation and make sure that we get them their vaccines, influenza vaccine and the pneumococcal vaccine, PPSV23. But again, another really important one that is going to help to be able to improve the quality of life as well as lengthen their life is supplemental oxygen. So this is a big one, okay? So supplemental oxygen, here's the crazy fact for supplemental oxygen. The patients with COPD, they might have to be on supplemental oxygen 15 plus hours a day. That is insane. And that's just a terrible, sad thing, is that they might have to be hooked up to this oxygen 15 plus hours a day. Now, here's the thing. When do we do supplemental oxygen? Because not everybody with COPD will get supplemental oxygen. We base it off of two criteria, okay? So one is we say if the patient's O2 sats is less than 88%, that's one factor. Or if the partial pressure of oxygen is less than 55 millimeters of mercury. These are the cutoffs. So anytime you get to below 88 on the O2 sats with the pulse ox, or you do an ABG and their PO2 is less than 55, we're going to want to start them on oxygen, okay? The other one is a little bit more of an exception. If we have a patient who has heart failure, or they're showing signs of that compensation because of the severe hypoxemia, which is the elevated hematocrit, so they have this, or they have an elevated hematocrit, and again, we call this the polycythemia because of that chronic hypoxia, then we change the threshold. Now it's actually even more important that we get them on oxygen even earlier. So now we set the O2 sats threshold at 90%. So now we'll start them on oxygen if their O2 sats drop below 90%. Or if we do an ABG and their partial pressure of oxygen drops below 60 millimeters of mercury. Because again, with this kind of situation, anytime you let the oxygen drop this low, you're putting the patient at risk of developing acute respiratory distress syndrome and them going into respiratory failure. So that's a very serious thing. Now here's the thing, with supplemental oxygen, and I can't stress this part enough, you don't want to give 100% oxygen. You want to give O2 in the range of 88 to 92% is the range that you want to give the supplemental oxygen. Let me explain why. I know it seems crazy, but you don't want to give them high flow oxygen. And the reason why we want to do this is we'll probably put them on a nasal cannula. You could do a Venturi mask, But nasal cannulas are better, and the reason why is they're not going to allow, you can control the air a little bit better with this one. If you put them on a non-rebreather, you're pushing a lot of oxygen in. So usually nasal cannulas are going to be the best one for this one, or a Venturi mask. But here's why you don't want to give them high flow oxygen. You remove that hypoxemic drive, okay? Remember, if a patient has low oxygen, okay, low partial pressure of oxygen, let's say, again, less than 60 millimeters of mercury or 55, again, one of the two, what does that do to these chemoreceptors? So again, what were these little guys called? Remember, they were actually the peripheral chemoreceptors. They were located where? They were located in the actual carotid body or in the aortic bodies. And again, what were these things called? Again, they were called peripheral chemoreceptors. Now, remember, they were stimulated whenever there was hypoxia. So, because of that, what did it do? It activated the nerves, right? Remember those nerves, the glossopharyngeal nerve and the vagus nerve? Whenever these guys are stimulated, they are going to send signals to the medullary respiratory center. Remember that medullary respiratory center? He actually sends signals down and then will go stimulate the intercostal nerves and will stimulate the phrenic nerve, which will cause contraction of the diaphragm and the intercostal muscles, particularly, in this case, going to be the external intercostals. But it's going to be at a higher rate and a more deep, right? So we're going to actually help us to get more air in. It's going to help to basically hyperpnea. That is the purpose of this. Now, if you give them too much oxygen, high flow, what's it going to do to their oxygen level? It's going to increase it. What are you going to do now to their hypoxemic drive? You're taking it away. If you take their hypoxemic drive away, you don't stimulate the peripheral chemoreceptors as much. Because of that, you won't stimulate the actual medullary respiratory centers. Because of that, the diaphragm and the intercostal muscles aren't going to contract as much. Guess what you can do? You can push them into respiratory failure. So that's not what we want. So it can be very dangerous if you give them too much oxygen. Another thing that they're actually finding, here's the thing, with hypoxemic drive, they're finding that this is not as common, and it's more due to that actual hypoxemic vasoconstriction nowadays. So they're saying that actually one of the big things is that our lungs is so good at being able to auto-regulate the blood flow to different areas of the lungs. Wherever there's less ventilation, we'll constrict. Wherever there's more ventilation, we'll dilate. If you have hypoxemia and you give them too much oxygen, you affect that hypoxemic vasoconstriction. So again, two mechanisms of why we don't want to give a lot of oxygen is you can take away their hypoxemic drive via the peripheral chemoreceptors, or you can throw off the normal autoregulation mechanism, which is that hypoxemic vasoconstriction. Okay? So that's important that we understand that. Okay, so these are the big things. We really want to instill this immediately because this is going to help to lengthen their life and help to be able to improve quality of life as well. All right. The next thing that we do, and this is kind of like the best kind of go-to usually, is we put them on bronchodilators. What color shall we use? I like this color. Let's go with this one. So we're going to put them on bronchodilators. Okay? Now here's the thing. With the bronchodilators, we're going to have two types. We're going to have the first one, which are going to be our anticholinergics. Okay? So we're going to have the and I'll explain what these are. Anticholinergics. And then we're going to have the beta-2 agonists. Okay, now with these, the anticholinergics and the beta-2 agonists, you have SABAs and SAMAs, for the SABAs and SAMAs. So SAMAs is your short-acting muscarinic antagonists. Okay, so short-acting muscarinic antagonists. And for the beta-2, these are going to be short-acting beta-2 agonists. All right? For the next one, you also have what's called LAMAs. LAMAs are long-acting muscarinic type 3 antagonists. And then for beta-2, it's going to be long-acting beta-2 agonists. Now, this is not enough. We should have an example of some of these drugs. So SAMAs are called, usually the most common one is ipratropium. Ipratropium. A LAMA is usually going to be tiotropium. For a SABA, this is what you commonly hear, albuterol. And for LABAs, this is usually formoterol, maybe even salmeterol. Okay, now these are the classic drugs that we look at and we utilize in patients who have COPD. This is a big one, bronchodilators. Now, let's say that someone has mild, intermittent symptoms of COPD exacerbation. The first thing that we would give in mild or intermittent is we would give a combination. It's actually best given a combination of a SAMA and a SABA. So in a mild or intermittent state, we give a SAMA and a SABA. They work better. And we can give them with a meter dose inhaler, with a spacer, which helps to basically propel it into the lungs and drag it down into the lungs. Another way we could give it is a nebulizer. So there's two different ways that we could give it. We could give it via what's called a meter dose inhaler, or we can give it via a nebulizer. Okay? Now here's the thing though. What if a patient is taking a SAMA and a SABA conjunctively, but over time the frequency of the symptoms is increasing regardless of utilizing the SAMA and the SABA? Or you do a pulmonary function test and their FEV1 drops below 60%. Oh my gosh, that's bad, right? So then what do? Then we resort to a LABA and a LAMA. So now let me erase this so we have more room. If the situations get moderate or severe, again, we categorize that by them using a SAMA and a SABA and still not actually treating the symptoms, or if the FEV1 drops less than 60%. So again, FEV1 less than 60%. That's one of the big things. Or if their symptoms are still occurring regardless of the treatment of the SAMA and the SABA, then we do a LAMA and a LABA. Okay? And again, with this, we can do a meter dose inhaler. Okay? But this is how we would go about treating this situation. Now, what I want to do is, before we move on to the next drug, is I want to talk about how these drugs work. Just a little tidbit, right? So if we go over here to the first one, what we have here is we have kind of a little cut section of an actual airway. So this is an airway here, right? And then here we're going to have the smooth muscle, which is surrounding the airway, the bronchial smooth muscle. On here we have two types of receptors. One is called an M3 receptor. Okay, that's a muscarinic 3 receptor. On the other side, the opposing side over here, we're going to have a beta 2 receptor. The muscarinic type 3 receptor is for the parasympathetic system, for acetylcholine. The beta 2 is going to be for the sympathetic system. If you guys remember, back from whenever we made videos for the physiology on this, right? When acetylcholine binds here, it causes contraction. So it increases the calcium levels inside of the cell and leads to contraction. That contraction is going to lead to bronchoconstriction. If you remember, for the beta 2, this is going to be norepinephrine or epinephrine. And when they bind onto the beta 2 receptors, they actually increase the production of what's called cyclic AMP. Cyclic AMP is actually going to cause relaxation of the actual smooth muscle. Now, here's what's kind of confusing for some people, and I want to make sure that I kind of show this, especially with the physiology. So I'm going to do a small little muscle cell down here for a second so I can explain this. Here's a small muscle cell, okay? We have a particular enzyme inside of this cell, and if you guys go back, watch our smooth muscle physiology video, this will make more sense. But we have an enzyme, and this is called myosin light chain kinase. So myosin light chain kinase. And this enzyme is needed in order to be able to phosphorylate the myosin. So it helps to be able to stimulate myosin and then undergo contraction. Well, what happens is whenever you have an increase in cyclic AMP, that activates an increase in protein kinase A. Protein kinase A phosphorylates myosin light chain kinase. When you put a phosphate onto this guy, you actually inhibit it. So now, is he able to phosphorylate the myosin and trigger the smooth muscle contraction? No. So because of that, that's going to result in smooth muscle relaxation. So that's how this happens. So I just wanted to make sure I explained that, because sometimes when people associate increased cyclic AMP, oh, that must mean there's going to be contraction. In this case, because it activates the protein kinase A, which inhibits the myosin light chain kinase, it's going to cause smooth muscle relaxation. So that explains that part. And again, going off of this, calcium is just going to increase, which activates calmodulin. So if you guys remember, calmodulin activates CAM kinase, and CAM kinase will activate the myosin light chain kinase. All right? So that should explain that part. Now, we have to understand now, if I give drugs that are anticholinergic, that means what are they going to do? They're going to bind onto, so let me give a drug, and again, this drug could be a SAMA, all right, or it can be a LAMA. And what they do is they block acetylcholine from being able to bind. So again, acetylcholine won't be able to bind here. Because of that, is the calcium levels in the smooth muscle cell going to increase? No. Is it going to activate calmodulin and CAM kinase? No. Is it going to activate myosin light chain kinase? No. Is the smooth muscle going to contract? No. What's the overall result? Bronchodilation. Think about it in the opposite sense here. This was causing smooth muscle relaxation already. If I give a drug like a SABA or a LABA, is the norepinephrine going to be able to bind? No. But here's the thing. Instead, this guy acts just like norepinephrine. And if you give a lot of it, it's going to bind onto this receptor. It's going to act as an agonist. So it's going to bind onto the receptor, and it's going to increase the amount of cyclic AMP inside of the smooth muscle cell. That's going to activate lots of protein kinase A. That's going to inhibit a lot of myosin light chain kinases. That's going to lead to smooth muscle relaxation. And that's going to lead to bronchodilation. All right? So these two are great in conjunction. That's why we want to give them. If you had to pick which one is better, it's the anticholinergic though. Okay? So if you had to pick which one was better, it's anticholinergic, but again, they're best given in conjunction with one another. All right, so that should explain that process there. All right, so the next drug that we're going to talk about is your corticosteroids. Them good corticosteroids. Now, steroids, you don't want to use these a lot. Again, they have a lot of systemic side effects that they can produce, so they're not always the best to give. Generally, they're only given, especially systemic, like IV or oral steroids. So you could, in acute exacerbations, so let's say that someone has an acute exacerbation of COPD, then we can give IV or PO steroids. That'd be something that we would give it. We wouldn't do it for a long period of time, again, because systemic steroids has a lot of side effects. But we could give IV methylprednisolone or PO prednisone. Those are things that we could do. But usually we give inhaled corticosteroids. Okay? So inhaled corticosteroids is generally what we can give. And whenever we give inhaled corticosteroids like fluticasone, we generally want to make sure that we're giving this, and especially, remember what I told you, we give a LAMA and a LABA if someone has moderate or severe signs of COPD. We give inhaled corticosteroids, and you give it usually if giving a LABA. Remember, when we talked about in asthma, the black box warning, never ever give a LABA unless you're giving it with an inhaled corticosteroid, okay? Because it can make the symptoms even worse, okay? So inhaled corticosteroids are usually given to help a patient who's having, again, more moderate or severe symptoms of COPD, and the SABA and the SAMA just aren't cutting it. Then what we can do is we can give them maybe a low dose inhaled corticosteroid and a LABA, okay? And even a LAMA with combination there as well. But again, acute exacerbation, something as having a very severe exacerbation of COPD, maybe because they have pneumonia, maybe a pulmonary embolism, maybe heart failure, whatever it might be, is something that triggered it to get worse. We can give them an IV or PO steroids if necessary to be able to treat the inflammation. So steroids, how they work is very simple, right? Your mast cells, they can release a bunch of different types of cytokines, right? Prostaglandins, leukotrienes, histamines, all those different chemicals. And what these guys do is they activate our white blood cells. And then from that, our white blood cells are designed to be able to come to that area. So they'll be activated and they'll undergo their migration and chemotaxis to wherever the area of inflammation is. When we give steroids, what that's designed to be able to do is to inhibit the cytokine release, to inhibit the activation of those white blood cells, and to inhibit the migration and chemotaxis of those white blood cells to where the actual inflammation is. So that's the job of these actual steroids. And again, they're pretty good at being able to treat acute exacerbations, and also they're good at whenever you have a patient who's going to be having to go on a LABA because they're having severe symptoms or moderate symptoms, or their FEV is less than 60, or just the SAMA and SABA aren't cutting it. All right, then we can give them an inhaled corticosteroid like fluticasone. All right, the next drug that we can give, we usually never give it by itself. We give it if we, with other drugs, like depending if they're on a LABA, and an inhaled corticosteroid is called a phosphodiesterase inhibitor. So we can give what's called a phosphodiesterase inhibitor. Now there's two types that we could do. One is called theophylline, and a newer one is roflumilast. Now, roflumilast is more of a phosphodiesterase 4 inhibitor. So it's a little bit more specific, whereas theophylline is not as specific. But either way, we can give these drugs. Okay, now theophylline is one of those drugs that we usually give to a patient who has such severe COPD that we need to give the patient diaphragmatic rest. They are just having to work so hard to breathe that we could give them this drug, and it really helps to be able to treat that severity by giving them diaphragmatic rest. Now, these drugs, however, can cause some pretty intense side effects. So we have to be careful with giving theophylline or roflumilast because they can cause some pretty nasty side effects sometimes. Now, how do these drugs work? It's pretty simple, really. What happens is, think about it like this. You have a drug, right? So let's say that here we go through this pathway here. Okay, here is this molecule called adenylate cyclase, right? And then here we're going to have, let's say here's a G protein. Okay, here's a receptor. And some chemical binds on here and it activates a G protein. That G protein will then come over here, activate adenylate cyclase. Adenylate cyclase takes the ATP and converts it into cyclic AMP. And then remember what cyclic AMP does in this smooth muscle, right? It activates what? Protein kinase A. And protein kinase A inhibits the myosin light chain kinase. And what does this result in? Smooth muscle relaxation. So think about this, guys. We have this would be commonly, which kind of thing would do this? Norepinephrine, right? Oh my gosh, let's fix that. Norepinephrine or epinephrine, right? So here's the thing. Cyclic AMP has to get degraded though, because we don't want this to happen all the time in a cell, right? So cyclic AMP generally gets degraded. And who does he get degraded by? Phosphodiesterases. So what phosphodiesterases do is they basically break down cyclic AMP. What if we had a drug that inhibited the phosphodiesterase and we could just continue to increase that cyclic AMP in the cell? Guess what? We do. Theophylline and roflumilast. You give those drugs, they inhibit the phosphodiesterase. Then the cyclic AMP levels build up. protein kinase A levels build up. More inhibition of the myosin light chain kinase, and then intense smooth muscle relaxation. So you can see how these drugs have the ability to help this. So again, these actually inhibit the phosphodiesterase. So that's how these drugs would work. Okay? So we can give, again, phosphodiesterase inhibitors. These are usually never given alone. You can add these again for patients who are having severe exacerbations and need diaphragmatic rest. Another one I'm going to kind of shimmy in here is they give this to patients as an anti-inflammatory effect. They can give antibiotics, but a particular antibiotic that has been found to have anti-inflammatory effects. So they can do long-term antibiotic, and this is azithromycin. And if you guys remember, azithromycin is an actual macrolide. So he has an anti-inflammatory effect, which is important for COPD. Okay, so these are the things that we would generally utilize for patients who have COPD. As a quick recap: smoking cessation, vaccination with influenza and pneumococcal vaccine, supplemental oxygen is the hinge point. You need to make sure that you remember this one. Bronchodilators that are anticholinergics, beta-2 agonists. If you had to pick which one is better, anticholinergics, because COPD is filled with a lot of acetylcholine in those synapses. Again, next one as second line is corticosteroids, okay, generally inhaled, and especially if you're giving it to patients who have severe or moderate signs of what? COPD, and the SAMA and the SABA aren't cutting it. Or their FEV1 is less than 60%, you can give it to these patients, especially if they're taking a LABA, and LABA can never be given on its own. And if someone is having an acute exacerbation, we can give them IV methylprednisolone or PO steroids. And the last one, kind of that little Hail Mary one, is the phosphodiesterase inhibitor like theophylline or roflumilast. They do that by inhibiting those phosphodiesterases, increasing that cyclic AMP, and helping to relax those smooth muscle cells. Okay, so again, this is generally how we would treat a patient with COPD. All right, engineers, so in this video, we talked about the treatment of patients with COPD. I really hope it made sense. I hope you guys enjoyed it. If you guys did, please hit that like button, comment down in the comment section, and please subscribe. Also, if you guys get a chance, go down into our description box, check out our Patreon, our Instagram, our Facebook, even our GoFundMe page if you guys could. If you guys could donate any money, we would truly appreciate it. All right, engineers, as always, until next time.